Thank you. So shifting gears from our break time musical interlude and getting down to business, welcome to Data for M&E, Source Systems and Quality, including HMIS. This is a very exciting session with, three presentations today, although I am going to make one last call for Olatunde Raimi. Nope. Oh, you are here. Come on up. Come to the front. 1 second. Okay, this is a pleasant surprise. Just kidding. We do have, 4 present. You know what? We're gonna switch up the order. Is what we're going to do. So we have 4 very exciting presentations looking at different aspects of data for M&E. Emphasis on HMIS, and 2 of the presentations and higher overviews in the others. So while we figure out the 4th presentation, I'm going to go ahead and introduce our first speaker, Laura Meyer. Laura is a researcher at Mathematica with nearly I'm a little scattered. I should introduce myself. My name is Jamaica Corker. I am a program officer at the Bill and Melinda Gates Foundation and a last-minute substitute for my colleague, Wynne Brown, who could not travel because of a knee injury. So I get the pleasure of leading this session and moderating you through these very interesting and informative presentations. We do have 4 presentations. I am going to ask the speakers to stick to 15 minutes or fewer. I think this is a pretty rowdy audience, and I do anticipate some good questions. Want to leave some time. I see Clea and Lisa in the audience, so I know there'll be some hard-hitting questions. Do want to leave time at the end for engaging Q&A. So we'll go through all 4 presentations, then we'll have the speakers come up, and we'll have a 15, 20-minute Q&A period at the end. So without further ado, we're going to start with our second scheduled presentation with Laura Meyer. Laura is a researcher at Mathematica who has nearly a decade of experience in quantitative impact and mixed methods evaluations in the areas of health system strengthening, early childhood development, and education. Her prior research on family planning includes a mixed methods analysis of interventions that aim to reverse the stall of fertility decline funded by the Packard Foundation in Western Kenya, and the evaluation of the Challenge Initiative that will be the focus of today's presentation. Laura holds a master's in public policy from the University of Chicago. Laura, take it away.
Hello, and thank you for joining us today. I'll be talking about an impact evaluation that we conducted in 2020 and 2021 of the Challenge Initiative, or TCI. The work was conducted with my outstanding colleagues from Mathematica and Avenir Health and funding from the Gates Foundation. As you might guess from the number of authors, it was quite a large and involved evaluation, and it's hard to pack it all in, but I'll do my best. The evaluation of methods I'm focusing on today contributes 2 new innovations to the field. There is increasing attention, and with good reason, paid to health system strengthening for family planning and for other important health outcomes. It's something that's really, really hard to do, and it's possibly just as hard to measure. USAID identified this as something that was important back in 2017 when they were developing their learning agenda for system strengthening, and it still remains an important gap. Our contribution was to take the synthetic control method, a relatively new approach that had been used for policy and systems level changes in other sectors. We took the method and we married it to the richness of HMIS to learn as much as we could about the effects that a package of family planning interventions and capacity building tools can have on the family planning uptake and services at the level of local systems. So we were brought in to evaluate the TCI 3 years following the beginning of implementation to help inform the plan scale up. Our entire evaluation included implementation and a sustainability study and a cost effectiveness study. But this presentation will focus on the impact evaluation, which was guided by the learning question: what is the measurable impact of TCI on family planning outcomes? So I'd hope that my colleague could go first, but in the meantime, because he'll be able to give sort of the firsthand experience of being an implementer, but sort of the bird's eye view from the evaluator's perspective, it's helpful to provide some overview. So it relied on the motivation, the coordination, and the leadership of local governments. And by local governments, we mean varying subnational levels. So going forward, we'll follow TCI's practice and use the term geographies to sort of take in all of those different levels. Secondly, the program is simply massive. It spanned 10 countries, more than 90 local governments across 4 different regions. In some ways, it comprised really 90 plus different interventions in terms of the complexities of local government engagement, data systems, length of implementation, specific interventions, and all of the other contextual factors. It was a challenge not just to the local governments who participated, but to those who managed it, monitored us, and to those of us who were tasked with evaluating it. So this slide outlines the basics of the method using totally made-up data. First, you take time trends and an outcome of interest from your intervention unit of interest, where a program was implemented, which I show in dark blue here. And sort of a note about the outcomes, what you're looking for, and the reason you would want to use a method like synthetic control is you're looking at an aggregate outcome that you don't have individual level data, you don't have a survey over that same period of time. You sort of need something that's aggregate, like voting rates or GDP, or something that where you just don't have like a tie to individual level factors. So then you collect the time trends of the same outcome for the same period for a set of other geographies that are likely to be comparable to that unit. I show these in yellow. These potential comparison units are called the comparison or the donor pool, and that they could contribute to the synthetic control that you create, but they may or may not. As you see, none of the yellow lines by themselves are a great match for the blue line. So then, to actually calculate the synthetic control, you run a statistical algorithm. Programs exist in most of your standard software, and it'll identify the combination of weights that will most closely match the pre-intervention time trend for your intervention unit. In this case, it assigns a medium weight to all 3. The resulting weighted average, which you see shown here with the blue dotted line, pretty closely matches the actual trends of the intervention unit in the before period, which is what you want to see to consider the comparison credible. The assumption is, in the absence of the intervention you're studying, the trends would be similar after the intervention. You have to look at the model in other ways, but if it passes all of the tests that you set out in advance, then you interpret the difference between the observed trend after the intervention and the synthetic control as the impact of the program. Here, those 2 lines are close before and then diverge after, so that we would call the results illustrated, evidence of positive impact. So we implemented the analysis in 4 different countries: Nigeria, Uganda, India, and Kenya. In each country, we went through a pretty rigorous 3-stage selection process to choose the intervention units we could comfortably study. First, we had to pick a level of analysis. This was possibly the hardest part of the entire evaluation. TCI's levels of implementation varied within and across countries. Within each country, we selected the analysis level that matches closely to the implementation level. In Nigeria, that was states, Uganda and India, districts, and in Kenya, counties. Then we selected the subset of TCI geographies with the longest implementation. We also had to eliminate those that we considered too unique to match, like large national capitals. We're talking Nairobi, Kampala. There's really only one of those. And then others that had poor data quality, we unfortunately also couldn't include. Then we engaged in a similar process to narrow down the comparison pool to exclude any that were systematically different or, again, had inadequate data quality. On this slide, I want to underline one key feature: the data intensiveness of our analysis and of the synthetic control method in general. First, we pulled as much pre-intervention, pre-TCI HMIS data as we could, back to 2014 or 2015. Ideally, we would have gone back even further, but that was as far as we could go to access data that was roughly comparable to the present and of high enough quality. Second, we tried to pull as much post-intervention data as possible, which ended up being through December 2019, right before data quality and service provision started to be affected by the beginning of the pandemic. Finally, we used a variety of sources such as DHS, national censuses, to serve as covariates in our modeling process. These covariates helped to improve the quality of the match, making sure that the synthetic control was similar, not just in terms of the trend, but also to other demographics that are associated with family planning uptake. Our partners at Avenir implemented a standardized approach to converting HMIS data commodities and services to measures of contraceptive use or uptake, or coverage, depending on terminology you use. Estimated modern use, or EMU, our primary outcome, can be interpreted as the share of women of reproductive age covered by a modern method. There was a presentation earlier today on the fine points of this, so I'll focus on the points most salient for our use in the evaluation. Because they're based on service statistics, EMU cannot be equated with measures of contraceptive prevalence that we get from surveys. It worked well for our purposes because of the level of disaggregation, the frequency with which it's available, and because trends in these measures can serve as a useful proxy for changes in population-based measures. And because TCI's interventions were focused on achieving changes within these very health systems and improving the quality and quantity of the services they provided. An additional point of caution is when using these methods for an impact evaluation, we had to be it's absolutely critical to be cautious to not mistake data quality for actual impacts on service provision and uptake. So we went through a very deep process of data checks and corrections, focusing on trends rather than levels, and interpret these results in light of what we know about the data, the methods, and the context in each country. So this is a brief snapshot of our overall analytic approach. We used Synth, a package in R, a general model that included a subset of pre-intervention points and other covariates. We calculated the average distance over the entire last year we could at 2019 and used that as our impact estimate. Again, because that was basically the last full year of data we had before COVID. And as a last point, we're very careful to interpret findings in light of the broader family planning landscape. The impacts should be interpreted as the value added over business as usual programming and not the equivalent of the impacts we might see if TCI were implemented in more of a family planning programming vacuum. So then, after running the model, we went through a 3-step process of vetting the results that we got. We evaluated every single result on the pre-TCI fit, the covariate balance, and then did more of a qualitative vetting of the comparison pool and the weights. So we set standards on the maximum deviation of the pre-TCI trend. The picture right helps to show why we set the thresholds that we did. On the left, even though it's like right on that line of acceptability, it looks pretty good to me. But on the right, it just simply isn't a convincing comparison, and we just unfortunately had to throw that model out. As I mentioned previously, we also incorporated covariates. They differed across countries based on context. For example, whether family planning use is more closely related to whether a woman is literate versus whether or not she has secondary education, and data availability at the levels we were studying. Then we set standards for each and limits on how many small, moderate, and large differences we see before deciding the covariate balance was unfit, and once again, throwing the model out. Finally, there was another round of qualitative vetting. We looked at the weights. We looked at the weights that they received, and it looked at those that were receiving large weights. If any of the ones that received a large weight were just not a credible comparison according to our local experts, once again, we threw the model out. Unfortunately, this process meant that there were a large number of TCI geographies for which there is no impact estimate on the primary outcome or on another secondary outcome that was also derived from HMIS. 23 impacts out of the 49 we attempted is not what we hoped for, but we felt it was better to have 23 convincing models than more that we had to stretch our standards to accept. In geographies where we were unable to develop a credible synthetic control, we conducted a trends analysis to visually assess how growth in EMU compares to those with similar pre-TCI contraceptive prevalence, and if there was a shift in trajectory following the beginning of TCI. Unfortunately, I don't have time to go into those results here, but broadly speaking, they did not change our conclusions. So since today is focused on methods, I won't have time to go over the results in great detail, but I think it's helpful to look at them quickly. So here's an example of the resulting synthetic control and trends for 3 states in Nigeria. The solid line is, again, the observed trends in the TCI geographies. The dotted line is the synthetic control. The yellow line indicates the beginning of TCI in each state. Interestingly, in northern Nigeria, we only had 4 viable comparisons that had enough data quality. So each of these dotted lines you see is a slightly different combination of just 4 states. But Surprisingly, they all did very well, and those looked pretty convincing to us. As you can see, the trend closely matches before the yellow line and then begins to diverge after, which is the pattern associated with positive impacts. We determined small, medium, and large impacts. Small impacts were larger than 0.5, but smaller than 1. Moderate were 2 to 3 times our standard to fit, or 1 to 2 percentage points. And large impacts was anything more than 2 percentage points. So here we all see moderate to large impacts. Since we're focusing on the methods, I'll move quickly and summarize the rest of the results. If you're more interested in this, we still need to make the report available on our website, but we're going to do it soon. In Uganda, we had 2 districts with a credible synthetic control and large statistically significant impacts. In Kenya, we saw a large positive impact in one county and a small impact in another, but neither were statistically significant. In Uttar Pradesh, India, estimated impacts across 6 districts were 1 percentage point or less, including a couple of negative estimates, and again, nothing was statistically significant. Finally, in Madhya Pradesh, we see 1 large significant impact, but the rest were negative and insignificant. So zooming out, what impacts we were able to detect in the short post-TCI period we had available were typically less than 2 percentage points, which typically translates into a 1 percentage point or less change in population-based contraceptive prevalence. So overall limited improvements in contraceptive coverage relative to synthetic control. Where we did see impacts, they were typically in places where prevalence was lower to begin with, and there were few impacts where prevalence was already high. Finally, we are aware that there were some limitations to this analysis that we were unable to overcome with this method. First, we were unable to construct an impact estimate for the majority of TCI geographies, including some of the largest, and an entire region, Francophone West Africa, where data was unavailable due to provider strikes. Unfortunately, and then secondly, TCI geography's level of implementation, start date, and unit of analysis varied, making it difficult to compare the result impacts we did detect across countries. And then finally, the time frame was possibly too short to detect meaningful changes in outcomes and measure impacts of systems level interventions. These types of interventions often take quite a long time to really reveal their impacts and to achieve systems change. But once again, we didn't have more time to work with since we couldn't rewrite history and undo that whole pandemic. Now for the implications and lessons learned. This study, I think, really does serve as proof of concept that the synthetic control method combined with high-frequency administrative data is a viable approach for conducting rigorous evaluations of programs in global health and in other sectors, if you can access data on a credible outcome over a long period of time. If the data doesn't exist and you have the benefit of designing an evaluation ex ante, you're better off using traditional non-experiment or quasi-experimental methods. Which leads me to my second point, that we found that it is possible to use HMIS as an outcome for an impact evaluation of a family planning program, but there was still a lot more work to do to improve its quality and accessibility for research. And finally, we did learn as we delved into the relevant literature, as a relatively new method, there wasn't really a lot of consistency in standards that we could rely on to construct and evaluate our models. If and when the synthetic control method takes on wider usage, there is definitely room to work towards consensus without eliminating the role that context should play in design and implementation. Thank you.
Fantastic. Thank you, Laura, for a high-level overview of using HMIS data for measuring the impacts of the Challenge Initiative across a number of different sites and a number of different settings. As we move to our second presentation, I will say that this is an extra exciting session filled with last-minute substitutions, not just myself, but also for our second presenter. Those of you who are following the program will be expecting Olatunde Raimi. This poor man has received multiple emails from me in the last day about the session, but I realized it was a systems glitch and we've been communicating with the wrong author. So I'd like instead, late-breaking and exciting substitution, Oluwasegun Akinola, who's going to give us a deeper dive on monitoring related to the Challenge Initiative in the river states in Nigeria. And if you don't mind, just a very quick introduction to yourself so we have better context. Thank you.
Thank you. Okay. Good evening, everyone. Um, I'm Shegun Akinola. I'm going to be standing in for the author, Olaitunde Raimi, who is not able to make it to, but is a staff of TCI in Nigeria, and he worked on this paper, and I'm a co-author on this paper. I'm also excited to have two, please let me just, in a few seconds, introduce them. Our CCP, Professor Stella Babola from CCP, who is our research and evaluation lead. I also have Ian, who is the TCI M&A lead from the Gate Institute. I'm also excited that we are here. So with that, I would run through this piece of work that was done beautifully. And it's talking about one of our states in Nigeria, which Raimi is the M&E lead, as a technical support lead. It's talking about effectiveness of e-monitoring data validation, a platform on data quality, evidence of improved service statistics for decision-making in Rivers State. Like she said, the last speaker, Rivers State is one of our states where we implemented. We've graduated in that state, but we still continue to support the state. One of the key things as a form of outline, I'll be talking about the background, the significance of this study, of this abstract, program intervention, methodology results, program implications, and lessons learned. But one of the core things I like to bring to the fore is that for us in Nigeria, one of the issues with the HMI's data is that, yes, we have a robust HMI's data from the facility. It's known we have a good national DHI system that you are able to track data for HMIs in the last 10, 5, 15 years. However, as a form of background, the core issue that we have had are things around human computation, and she alluded to that in one of, issue of data quality as being one of the biggest issues that we face in Nigeria. And we have 36 states, so you can see data moves every month from the LGA down, from the facility to the LGA, and then it's uploaded on the DHIS. However, between this data flow system, there are issues, human data error, poor organization, management recovery. And TCI, one of the core things is to strengthen our data quality. That's one of our core duties in TCI, and that's what we'll continue to implement. You have poor data communication between the facility staff. In this it's talking about where you have issues around provider, record officers, and even from the data from the registers, because client comes in and then it's imputed in the register, but it needs to be, it needs to enter the monthly summary from that goes and it's uploaded on the DHI system. So I'm trying to explain the process so that you understand where we have these gaps. And then security. What's the significance? For us, reliable data and accurate health data is essential to improve service delivery for Nigeria. Monitoring and evaluating health programs, so you are able to know what is going, you are able to track. And then prioritizing support for health programs, including family planning. One of the issues, and I'm saying this, is that for Nigeria, yes, we have health programs that continue to receive maybe more support compared to family planning. You have malaria, you have other programs, MNCA, but so we continue to, ensure that we have quality data to be able to bring to decision makers to understand that family planning needs attention, and that if with quality data, we're able to provide this for them. For significance too, what we did for Rivers, which was different, was to develop what we call, because we knew what were the challenges, like I said, poor documentation errors, issue of data quality from the registers, was to develop what we call a web-based e-monitoring data validation system. And what does data validation mean? You validate data from the register, looking at all the data elements and looking at that vis-a-vis what you have on the monthly summary form before it is uploaded, because whatever enters the DHIS system is what is used, analyzed, like the last speaker said, analyzed, whether using any methodology. But before the data enters the HMI system, you need to ensure that that data is of high quality. And so what we did was to have what we call develop an e-base, and I'll be talking about that more, to address the issue of computation errors, eliminate outliers. So where you have condoms reaching like 1 million, and you're wondering, how is that possible? And so that will help you to detect errors outliers, enhancing data consistency and accuracy and validity. And that was what we did. And the core thing was for us to improve the service statistics for us, so that we're able to make, top state counterparts are able to make decisions with this data. But when the data is not of high quality, they're not able to, you are not even able to project that data at that level. For program intervention, what we did was to develop, many of you know the ODK, the open data, and we developed some key things there, simple and easy online and offline platform to be able to detect errors. Like I said, validate FP statistics generated, reported into the national HMI system, talking about the DHIs for decision making. And setting up, it was automated to address three core things: consistency, accuracy, validity, which are the domains of data quality. If you want to improve data quality, you need to address these three domains. And then, like I said, it was just to help, flag outliers, incomplete data sets. For example, if you look at it, our registers in Nigeria, one of the core data elements there that you need to fill is age. But you see that some of our providers are written AD, meaning adults. And so these are gaps, that we have, looked at. So this e-monitoring that we set up was to address all those outliers, was to address those gaps, competition errors. As a methodology, what we did was to train staffs, improve their capacity to be able to understand the importance of that, using the ODK. There were training sessions. I don't want to bore you with all this, using the ODK so that they understand what we're trying to do. And so what we did was to look, and we piloted this in 52 facilities, a demonstration site of TCI in Rivers State. Even though we work in 12 LGAs, our support was for the 12 LGAs, but we have 52 demonstration sites that we particularly wanted to see the change between the period where we had not introduced this e-monitoring for data validation, monitoring data validation, and the period that we looked at this 1 year after. What did we see? And these are some of the results that I will be showing you. And we developed a scoring. I would also develop a scoring to check those three domains that I mentioned, which are data validity, consistency, and accuracy. The results showed between the period where there was no, where we were just using the paper-based, because that's what we're known for, the paper-based data validation between March 2020 and February 2021, compared to the 1 year after of March 2021 to February 2022, you can see the significance in terms of the change that we noticed. Using that tool, we noticed the improvement in data quality, addressing all those documentation errors, and you can see the period before intervention and after intervention. Just that 1 year period, there was a lot of change for those 52 facilities. And that gave us, and we saw an improvement for, all in the HMI's data that we were submitting and reviewing and analyzing for Rivers State particularly. In terms of looking at, you can see in terms of the mode maximum, 193%. If you look at the overall score for the 12 LGAs where we implemented in Rivers State, you can see the score. Between the period that we introduced the e-monitoring data validation system, it went up, across all the LGAs, for all the 12 LGAs, and we're impressed about that, because compared to the period where there were issues of outliers, computation errors, incomplete data, we had addressed that within that 1 year period. In trying to, and in terms of program implications and lessons learned, we feel that the e-monitoring data validation has changed a lot of things. And with this, that has enabled the government to scale up to other non-supported TCI LGAs to use this, because they've seen the change that we have been able to demonstrate using the e-monitoring, and the state has been able to adopted that over the period from February 2022 this year. And we see that the use of simple tools, just using the ODK, which many people are known for, but because for us, we wanted to change the narrative. And we've seen how, that has helped us to quickly be able to interpret data, analyze data on time, and to be able to make some decisions on time compared to the paper time, and you still have some outliers to address over a period. Also, to be able to, using improved data, we've also been able to increase and empower some of our health workers and the record officers to be able to do more, because with the e-monitoring, they are able to be fast, because it's a simple tool, compared to when they need to do that with, using their biro, using paper-based and all that. So for us, that has changed the narrative, especially for these states that we looked at in River State. That ends my presentation. Thank you very much.
A big thank you to both our presenters, not only for very interesting presentations, but also for sticking to time. We're going to go back on schedule, but it will be no less exciting with our next presenter, Zeshi Fisher. Zeshi works with the Global Women's and Newborns Health Team at the Burnett Institute in Australia. She's a midwife with expertise in clinical services, public health, project design and management, and organizational governance. She's worked over many years on measurement and quality improvement initiatives. And being from Australia, I would guess she is thrilled to be at a big international conference that for once did not require her to travel halfway around the world, but instead the rest of us. So Zeshi will be presenting on routine measurement of sexual and reproductive health and family planning in 6 countries in the Pacific, with a review of HMS indicators and data availability. Zeshi, the floor is yours.
Thank you. It's very nice to be here. And thanks for coming. All right, so thank you, Jamaica, for the introduction. I'm really pleased to be here to be part of this discussion on HMIS, particularly and around all of the different nuances of data and data quality and improvement. So my presentation today will be on some of the key findings from a review of the Health Management Information System data for family planning and sexual reproductive health in 6 countries in the Pacific. And this work is part of a larger program, the Transformative Agenda, which is funded through the Department of Foreign Affairs and Trade in Australia and managed by UNFPA, the Pacific Sub-Regional Office, and implementing partners. And this review was done to really provide a foundation for informing the work of the program and designing priority actions for HMIS strengthening. And the reason why this work is so important is that HMIS underpins our planning, our management, our service improvement across family planning and SRH programs. We know that we need quality data, and I'm actually glad I'm coming off the back of this presentation around some of the issues with HMIS and how that impacts our ability to actually effectively manage and improve. So, HMIS, routine data. I expect I'm talking to a room of people who are familiar and work in this every day, but I actually want to go back to basics because they're underutilised. The data that comes from an HMIS is underutilised. It's a valuable resource. However, we often don't know, we aren't able to use those effectively. Why, and so what I'm starting here is why the HMIS exists is to support decision-making in health facilities and organisations. And sometimes we forget that the HMIS itself exists for the program, to actually serve the needs of the program. And actually a measure of HMIS performance is to generate quality data that can be used to make decisions. And for those decisions to be able to be made, that data needs to be available. And for the data to be available and used, it has to be of sufficient quality. And we say sufficient quality because it varies depending on the need. And also, it needs to be fit for purpose. So we need to know what the purpose is. So the other thing that we need to always come back to is that the system itself needs to meet the needs, the information and data needs of the users of that system at every single level. So we need to know what the demands are on that system. So in the Pacific, we have, it's a special place. It's a really special place. Across the Pacific, there's a unique variety of HMIS in use that countries are using. Some are using bespoke or custom public health information systems and electronic medical records. Some are using DHIS2, which most of you are familiar with, and a number of the countries in the Pacific are also using additional data collection interfaces or apps and data visualization software in conjunction with DHIS2. And although the digitisation of health facility data is progressing everywhere, most countries still rely on paper-based, largely paper-based systems. So across the region, it's been reported that the quality, I was one ahead of myself. The quality, availability and use of routine data is inconsistent, and that in many cases it is inadequate. And even though a lot of work has been done on HMIS improvement in recent years, the systems that are in use face ongoing challenges, including access to remote island districts, connectivity, resourcing, technical capacity, and all of these other challenges that have just been mentioned before. They're all real. They're seemingly insurmountable at times. So these challenges, they're well known. However, the specific gaps in SRH data have not been described, even though the challenges themselves are cited often, they're experienced every day by those who are responsible for the HMIS tasks. So the aim of this piece of work, it wasn't set up as a research project as such, it was set up to make an assessment of the situation so that we could inform our planning and our design of our work in the region. It was to identify opportunities and gaps so that we could inform our HMIS strengthening actions and the design of the work. Specifically, we wanted to identify gaps in SRH data availability, but also the availability of SRH data by key populations, so 4 key populations. And in this case, we're looking specifically at adolescents and people with disability. Our methods, first we undertook a mapping exercise across international facility recommended indicators and program-specific or domain monitoring initiatives to just really get a sense of what indicators are out there and what are the standardised and tested indicators that could be or should be monitored at a program and sub-national level if these choices were there to be made. We also reviewed information products, so that's quarterly and annual reports and dashboards to see what data was actually being produced regularly. And we looked then at also the facility monitoring tools, the registers, the tally sheets, etc. We also spent time in discussion with our government partners and also clinicians, midwives, nurses who were working at rural facilities and even directors of the reproductive health and health information system units. Of course, many limitations. COVID and the associated travel restrictions impacted the way that we collected data and what we could do. The lack of standardisation of tools. The uniqueness of tools between facilities meant that we couldn't actually review every single tool to see what was there and what was being collected. And because our initial intention was to actually have a look at what data was available against indicators, we needed the metadata. We needed to know how they were being calculated, what was the data requirement for those indicators, but we couldn't actually access that, and so that limited some of our analysis, or well, the review of the availability against national indicators. So the the initiatives and frameworks mapped. There's a list you can see here across some of the global initiatives and also those that have elements of recommended facility data that should be collected where possible, and also, like I said, these domain-specific initiatives. We included indicators that had HMIS as a preferred or alternative data source. And for the purpose of benchmarking only, we had to limit. So we looked at HIV/AIDS indicators only if they were integrated with reproductive, maternal, newborn, adolescent health. And we also, for benchmarking purposes only, didn't include the LMIS or the logistics and supplies indicators as well. So part of this initial mapping exercise, I wanted to just say before this slide, was that at an international and national level, most of the indicators that are used to monitor family planning are actually not using a HMIS data source. They're using a survey-based data source. However, and nonetheless, programs do need an annual reporting mechanism, and so without standard indicators, what we see in the Pacific is that countries are often using data to estimate indicators that are not HMIS indicators, for example, prevalence of contraceptives, which is fraught. It's really fraught. And so what we've done here is had a look at what indicators are being tracked at a national level and subnational level, if that's defined. And just I've given an example here specific to family planning, but we did this across all the SRH indicators with a HMIS data source. In family planning, we had 9 indicators as standard or tested indicators in the frameworks mapped. And then you can see in each of the countries that varying numbers of HMIS indicators defined. And I have to say here that Fiji, where we see there is nothing, didn't actually have a family health or reproductive health framework or monitoring framework at a national level. And some of these are using draft frameworks because the length of time in which these were not endorsed, we had to just use the draft indicators there. Fiji, even in their national operational plan, had no indicators on family planning. So it begs the question, how are we able to manage these programs if there is no data? So on that, we have a lot of data and we have a lot of time and we have a lot of resources. We have people, human resources, expense, infrastructure. We have all of these things that are inputs into routine systems, and yet there is nothing linking them to the mechanism by which they can be used. And that is just, I've put this here just to emphasize, this is why it's important. So the key gaps, and I'm actually going to run out of time, there's too much to say. The data demands, all right. So actually, to assess the availability, we need to know what's being demanded of the system. And what we find is that there in every country an opportunity to better assess and better know what it is that's being demanded of their routine systems, and articulating these so they can be translated into indicators and measures and reflected in the tools. We also looked at the degree that the systems could produce these standard indicators that we mapped. I haven't included the data here. And it's not really relevant except that it's a great tool or as a matrix to select indicators if they know what data is there. We also see that the information products that are being generated are actually opportunistic. They're not driven by the user needs, they're driven by what data is there in the system. And that impacts availability because when you think about availability as being the data that's there, that's needed, then obviously the needed data is then poor. And counting rules vary. The way that they're defined and the way that they're collected varies between countries and even between staff, between facilities, between provinces. So you find that the quality and therefore the availability of data to report on indicators is affected. I had an example. I'm going to skip that in the interest of time. But so you can see, these are not even all of the ways that clients are counted in the Pacific countries that we were working with. So it's very hard to actually be talking the same language and to be counting the same thing. And that really impacts the quality and the availability. So more key gaps that we saw, and these are really significant. In all of the 6 countries, in all of the information products that we mapped, that is all of the quality reports, all of the annual reports, none, 0% of routine information products published data by adolescent age on SRH. That's critical. How are we going to improve services and coverage for adolescents if we have no data? And I just need to mention here that most countries are reporting adolescent birth rate or fertility rate with HMIS data, but I haven't included that because it's not an HMIS indicator. So what we see is an absolute gap. And also, no SRH indicators are able to be collected by people with disability. This is another important area. And since this review, some countries have started to bring these fields into their reporting. However, they're not supported by standardised tools or identification, or they're not regularly analysed. And then, of course, every country has a degree of waste. And the issue with this is there are many data fields that are being collected every month in these monthly statistical reporting forms. However, they're not all linked to any means of analysis, of presentation. They will never be used. They'll go into the ether. And so, an example we had actually was that in Kiribati, they have a monthly form with more than 230 fields, and 9% of them are linked to an indicator. So where do the rest go? They never get used. They'll never get analysed. So that's really critical. Am I running out of time? Yes. Okay, 3 more gaps. Integration. I won't even talk on it, but just maybe I'll talk on it. There is data collection happening in different places, so you can't link clients. That is not adequate in terms of decision making or answering questions around other services integrated. How can we answer those questions? They're not there. Facility registers, they're not standardised. All right, let's move on. We all know this. They're unique between facilities. And also here, skills and motivation for HMIS tasks are not adequately supported. And I want to really emphasise, although we couldn't look at this deeply in the review, that motivation is a system issue. It's not an individual responsibility. It is the responsibility of the structure and the organisation to enable and support motivation within staff for HMIS tasks, or we won't see improvement, because actually behaviours of staff at every level impacts the way that data are collected, how they're reported, how they're analysed, etc., etc., etc. Okay, opportunities. I'm not going into this, but let's just say there's lots of opportunities. And I just want to say, this last point, let's come back to this last point on data being fit for purpose and actually knowing what fit for purpose is in our context. And I think if we just come back to that, we will be able to really drive improvements that make a difference for the people using the data. So, thank you very much.
Thank you, Zeshi. Really interesting to see a lot of work on a part of the world that I don't think is as represented in a lot of the research and conference presentations that we do. So moving on, last but not least, we have Bridget Adamo. She is a research associate and senior monitoring and evaluation technical advisor. Bridget has an MPH and over 20 years of work experience in international development, with technical areas of expertise in the M&E of family planning, tuberculosis, scaling up best practices, community-based HIV programs, and gender integration. She is an expert in indicator development and development of M&E plans. Bridget is currently with the Carolina Population Center at the University of North Carolina at Chapel Hill and is a senior advisor on both the Data for Impact and TB project and the Impact Assessment and Communications Hub. Bridget will be presenting on identifying gaps in the monitoring and evaluation of adolescent and youth reproductive health programs.
Thank you for that. Okay, so this research that I conducted was initially done under the Measure Evaluation Project. That project ended, and so now it's being disseminated under the D4I project. To give you a little bit of background on the significance of this research, 1 out of 6 people in the world is an adolescent, and by the WHO definition, that's an individual between the ages of 10 and 19. Action and investment to ensure that boys and girls grow up healthy and develop the capabilities for adult life is a global agenda. So young people, as we know, are recognized increasingly as a key population for reproductive health interventions because they suffer disproportionately from negative reproductive health outcomes, like unwanted or mistimed pregnancy or acquisition of STIs. So it's essential that reproductive health interventions that are designed for adolescents and youth are effectively monitored and evaluated so we know what works. The objective of the research was to identify gaps in M&E of AYRH programs. And to do this, I reviewed the M&E landscape of AYRH interventions, outcomes, and impacts, and sought to identify measurement gaps. I did this 2 ways. One was through a desk review of published peer-reviewed and gray literature. I also searched other websites, especially when I was looking for indicators that are being used for adolescent and youth reproductive health. That was websites like PMA 2020 or the Breakthrough Action Social and Behavior Change Indicator Bank, things like that. The other method was key informant interviews. I conducted these with in-country M&E and program staff because I really wanted to gather their perspectives and in-depth information on not only what indicators are they using, but also I wanted to hear about their M&E challenges, best practices, and lessons learned. So I spoke to 19 people from 18 organizations in 12 countries, and Zeshi, you'll be happy to know I spoke to somebody in Vanuatu, so the Pacific was represented. So from the desk review and key informant interviews, I extracted 816 indicators on AYRH. These were outcome and impact indicators. I did not collect indicators on input or process because those are often very project or donor or organization specific. I did not collect any indicators that were not specifically about adolescents and youth. I also did not collect any indicators on other topics related to adolescent health, like tobacco use or mental health or something like that, or distal factors. So these are really on AYRH higher level indicators. For ease of analysis, I organized them into 24 thematic categories, as you can see here. And it was important that I recorded the indicators in their original format, even if they were kind of crummy indicators, because I really wanted to see the breadth of the indicators that are out there. When I was selecting the key AYRH indicators, I looked at all 816 indicators and picked out the ones that were strong, high quality, and crucial for measuring progress toward an intended result. I analyzed the indicators based on standard indicator criteria, which for M&E folks, You guys know this already. And then for similarly worded indicators, I prioritize the indicator that was from a more well-known source, like the Lancet Commission on Adolescence or WHO. Okay, now we'll get to the good part. A lot of my findings, I am going to lump into data deficiencies. And I'm going to present the findings and kind of the discussion at the same time. So as Zeshi and Segun had alluded to before, there are problems with age and sex disaggregated data. So even when age and sex are recorded by primary data collectors, these disaggregations are often lost as the data is reported up. And even in high-income countries where the HMIS are better developed, nationally available data are often not sufficiently disaggregated by age to be able to actually focus on young people. The evidence base on very young adolescents is sparse. So very young adolescents are kids ages 10 to 14. Nationally representative household surveys, such as the DHS, the Multiple Indicator Cluster Survey, the AIDS Indicator Survey, they start with the age of 15. So they're not capturing this group or married adolescents. But keep in mind that obtaining data from this age group is challenging because it requires special consent and assent, challenges with institutional review boards, with getting community leaders' input and approval. And also you have to be very careful with how you are phrasing things in your data collection tool so it's appropriate for kids these ages. So for M&E people, you have to weigh the cost and benefit of including this age group also. Data on unmarried women and girls is universally lacking. In a large number of countries, unmarried women, especially unmarried adolescents, are excluded from surveys about reproductive health, or they're included, but they're not asked questions related to sexual activity, contraceptive use, and desired fertility due to sensitivities about sexual activity outside of marriage. And data tends to lump married and unmarried adolescents together, which is a shame since they have very different reproductive health needs. Most of the focus on family planning reproductive health programming is understandably on women and girls, but what that means is there's a lack of understanding on the needs of adolescent boys. And so data then is missing on what is working with adolescent boys in reproductive health programming. Both the literature review and the key informant interviews both identified a lack of data on vulnerable groups of adolescents. These would be adolescents from maybe ethnic minorities or who are street children or in juvenile detention facilities, things like that. But again, thinking about disaggregations, you also have to be careful because the more you disaggregate the data, the smaller your sample sizes become, and then the harder it is to draw meaningful conclusions. So that is something to keep in mind. Another data deficiency area is on non-heterosexual behavior. Traditionally, reproductive health and family planning programs, policies, and research have excluded non-heterosexuality, which reflects an assumption that heterosexuality is implicit in the core demographic topics of fertility and family formation. So there's a lack of data addressing the full spectrum of sexual experience among this age group. Around the world, we know mobile phones have become ubiquitous, especially among adolescents. And although digital health interventions are important for looking at health outcomes, the M&E of the digital approach itself has not yet caught up with implementation. So more research is needed to test that actual mode of gathering information, and is that actually working, and how is it working? Another group of findings is areas that need additional M&E. So one of them is access to contraceptive information and services. A lot of efforts have been made to monitor and evaluate access, but we need more innovative research methods and study designs to improve this area. There's plenty of evidence to support engaging the community to change norms and improve AYRH outcomes. However, few evaluations have been conducted to measure the effects of interventions at the community level, such as changes in norms, attitudes, and behaviors of community members themselves. How have parents thought about this? How have their attitudes or behaviors changed for interventions that are targeting adolescents? And certain key facets of reproductive health are not being tracked among adolescents and youth because they're not being measured, or they're not being measured consistently. This would include fertility intentions, agency, adolescent empowerment, areas like that. For people who have teenagers, or who work with teenagers, this should come as no surprise that there is a difficulty of gathering sensitive information from adolescents. Adolescents tend to feel shy talking about personal matters, particularly sexuality and sexual relationships, and even more so in socially conservative societies. So several key informants identified this reticence as a barrier to collecting data and monitoring their interventions. An underreporting gap is sexual activity. Respondents may be reluctant to admit to having intercourse at a young age or outside of marriage or with a same-sex partner, thereby underestimating the proportion of adolescents who are actually sexually active. This underreporting gap is also related to the way that sexual activity is defined, analyzed, or reported. So sexual activity generally pertains to having had coitus within the past month, whereas by default, all married women are considered sexually active. Questionnaires also need to use unambiguous language. Likewise, data collectors need to be well-versed and comfortable with terminology around sex that adolescents will understand and be familiar with. We know they have their own vocabulary, and you may not be talking the same language. Another underreporting gap is around induced abortion. Not only are reliable reporting systems typically absent where abortion is legally prohibited, but abortion itself is just highly underreported. It's very stigmatized, and there are also lack of funds and/or sanctions for programs to collect this information. Sexually transmitted infections is another underreporting gap. There's a problem with HMISs reporting this data consistently, and also for example, there are no globally accepted indicators for chlamydia, so it makes it very hard to monitor this. Gender-based violence, we know, is also hard to get data on. The lack of data on the nature, prevalence, and incidence of GBV is a barrier to effective interventions and policymaking. Due to a myriad of reasons, people are reluctant to report on this or report on being either a victim or a perpetrator of sexual violence, and this is particularly true with collecting data on boys. So with the indicators, I found a lack of standardization. This is not unique to AYRH. This is kind of an overarching problem. In the interest of time, I won't give examples, but suffice to say that when you don't have standardization, it's really difficult to compare apples to apples. So with that list of 816 indicators across 24 thematic areas, that resulted in 103 recommended key indicators. And they were selected because they met these criteria. So to conclude, here are some of my recommendations. One is to use a selection of relevant key indicators. as recommended in the paper. And of course, programs and donors and interventions should use their own customized indicators, but it's also important to use key indicators and also to use standardized indicators wherever possible, and not to create your own variation of an indicator that's already out there. HMIS systems need to improve their ability to collect age and sex disaggregated data. And a little hot tip in M&E, if you are collecting data on a person, whether it's for family planning or malaria or HIV or something, it should always be age and sex disaggregated at a minimum. Improve the inclusion of adults from marginalized groups as appropriate for your program. Include specific terms when collecting data from adolescents. Obtaining reliable data depends heavily on data collectors using clearly understood terms and standard definitions for each indicator. Include important social determinants of health. Increase the use of digital technology like mobile phones and tablets. Expand efforts to monitor adolescents' access to contraceptive information, and then develop and validate standardized indicators for STI, and encourage the inclusion of these in HMISs as well. So to access the full report, you can go to the D4I website, where you can see the whole list of indicators, the good, the bad, and the ugly, and what those 103 recommended indicators are. Thank you.
Thank you. Thanks to all four presenters on a wide spectrum of methodologies and contexts for looking at data for M&E. We have just about 10 minutes. We do need to vacate the room at 5:35. So I'm going to ask the speakers to come to just the front row, maybe, for in the interest of time here. So actually come on up. And we'll take first round of questions and see how much time we have following that. So questions from the audience. First come, first serve. We've got one over here. Anyone else want to go in line? Okay, we'll take this and we'll go directly to the presenters.
Thank you to the presenters. I'm Veke from Liberia, and my question is to the team from TCI in Nigeria. So your e-monitoring system, how do you synchronize your findings to the national DHIS tool? That's my first question. And the second one is, like the second to the last presenter said, clinicians are not motivated to collect data. So how do you cross-check the findings in the register at the facility? Do you check another sources to make sure the data quality at the facility is of good?
Do you want standing up to answer so that I can see?
So thank you, ma'am. The e-data validation system is not talking about synchronization into the DHI system. What it's doing is to address the gaps that exist from the HMIS register and the monthly summary form that is uploaded on the DHIS. And so if you have those data elements around age, methods, outliers around 1,000, the e-validation would help you address that when you are looking at the monthly summary form. Remember that if you are using the paper-based validation system, what it does is for you to look at the two registers and see whether the addition or the total tally with the monthly summary form. But with the e-validation system, it helps you to quickly know what is the gaps. If you are looking at 1,000, for example, for condoms for the month, and you are looking at 200, you know that there's a gap already. And so it can quickly help you raise documentation errors, and that, if you quickly address that, because what is key for us in Nigeria is the monthly summary form that is uploaded on the DHI system. And, and that is the HMI system that we analyze, and we still do some CYP adjustment for short-acting method. And like I said, Ian is here. So for us, that data is key to us. If any data across for a short-acting method or for longer goes wrongly and that is what is analyzed, that's a wrong impression. And it takes 3 months for us in Nigeria to quickly be able to update that. And after 3 months, you are not able to update that. So for us, what goes between the HMI's register, which the record officers or the providers fill in, and the monthly summary form that is uploaded on is where we are addressing with the e-validation system. And so if you are able to address those gaps, you are sure that anything entering the data that is analyzed is the correct data, and you are able to say that there's no incomplete data or documentation errors or gaps. I think that is clear. Okay.
Other questions? Lisa?
I have a question for Bridget. I know it didn't sound like the aim of your analysis or your review was to look at it like by country, but I was curious, did any countries stand out as really having, a strong indicators more so than some of the other countries, or was it kind of a hodgepodge across?
Bridget, do you mind standing up? Sure.
No country stood out. In Vanuatu, because it's a small country and because it's comprised of, over 80 islands and it's really spread out and everything, they had a problem with disaggregations and having really small, really, like when you're looking by island or something like that, they had these small little pockets and small samples. So that was one of their issues. One thing that was interesting, though, speaking of good or bad indicators, is it was really interesting looking at different like WHO indicators or USAID indicators, and there was a discrepancy even within WHO or within USAID. And lack of standardization. So even within the same organization, they're not standardizing their indicators. So that was, one of my findings.
We have time for one or two more questions, and there are two here, and then Ian in the back, and then we'll turn it over to the presenters.
Yeah, thank you, all the presenters. I really want to say I appreciate your works. My name is Olayinka from Planned Parenthood Federation of Nigeria, PPFN. I see a lot of gaps identified. I'm curious to know, how have you helped the country or the government to correct this? Because like what you just said now, even from the donors, you even see some of the indicators different. Like the age group, you can see from the UN have their own different age group, and WHO has another age group for the adolescent. So how are we trying to address this so that we can have a unified indicator?
Thank you. Great question about what to do from here. And we'll take one last question from Ian Salas in the back.
Thank you to all the presenters. This question is for Laura, the first presentation. And thank you for talking us through the synthetic control method. And I know that this methodology has been pioneered or introduced in the economics and political science literature. And in those cases, the treatment and donors or potential controls are clearly delineated. In most cases, the potential controls definitely are assured to have no type of intervention that can impact the outcome. I think I noted in the application that there is a different interpretation that you have adopted. Is that something that you have seen others do as well? I think that's the interpretation of it as the value add of TCI, acknowledging that there are maybe similar programs impacting on FP, and hence could be interpreted differently relative to the synthetic control in other fields when applied.
Thanks, Ian. Laura, I'm going to hand this to you for the specific question and then finish up with all of the presenters on any recommendations for helping governments.
Thank you. So I don't think we've had anyone where they were specifically using the value-added phrasing, so that is something that we added to the interpretation. I don't think it's always quite so clear-cut. Like one of the big examples is like a new cigarette tax in California. I don't know if they went through and they assessed the state and local taxes and any changes that occurred in all of the other states that were included in the comparison pool. So I don't know if the value-added has been used, but I think that, don't know if there is nothing happening that would in any way be related to the intervention that we're studying, because I think, the world is a very complex place. There are changes happening incrementally, globally, all over the place, and trying to eliminate all possible potential contaminants is usually just not possible. So thank you.
Thanks. I'm going to hand it off to any of the speakers here for what. Okay, great.
To answer your question about how recommendations for how to standardize indicators, was that kind of the gist of your, and get people to be on the same page in governments? Okay, so the quick answer to that is using indicator reference sheets. And everybody so having indicator reference sheets for your indicators. So at least among the people who are using your indicator, because even like the example that I gave with people having different ideas about even what sexual activity is, if you have an indicator reference sheet that clearly defines the indicator, how it's calculated, how it's disaggregated, the purpose, how it's maybe visualized, that is very helpful. There's a family planning reproductive health indicators database that you can access it on the D4I website. It was created under Measure Evaluation. That has standardized indicator reference sheets that USAID uses. And so it's just putting in a plug for making sure that people are using indicator reference sheets so everybody has the common definition, not coming up with new little nuances, because sometimes the nuances don't affect anything, and sometimes it's just enough of a change that it actually does change the indicator. So it's also just advocating for that and looking, thirdly, when you're looking for indicators or developing indicators, whether you're a government or a project or whatever, look at what's already out there before inventing new ones.
Actually at time, and we do need to vacate the room. So I want to thank the audience and the Prevent Centers for your flexibility and patience, and a big thank you to all 4 presenters for an excellent set of presentations today. Thank you all. Enjoy the rest of the conference.